Dr. Komala, Assistant Professor. A warm welcome to you all for the guest lecture on the occasion of World AIDS Day to create awareness regarding AIDS. It is organized by the Department of PG Studies in Swastavritta in association with NSS Unit JSSAMC Mysuru. Now I welcome Dr. Arya for continuing the session.
Pranams to His Holiness Mahaswamiji. Namaste and good morning to one and all. As William Blake said, knowledge is life with wings so that one can explore new heights of flying. The world has made significant progress since the late 1990s, but HIV remains a major global health issue, and like many other major health issues, it faces additional challenges during the COVID-19 pandemic. HIV prevention, testing, treatment, and care services are all being disrupted, particularly in countries with fragile health systems. Any slowing down in provision of these services will leave many vulnerable populations at risk of HIV infection and AIDS-related death. Nevertheless, all over the world, health workers and community representatives are doing their utmost to keep the services going on. On this day, let's join partners in paying tribute to all those working to provide HIV services and in calling on global leaders and citizens to rally for global solidarity to maintain essential HIV services during COVID-19 and beyond. We, the students, staff from the Department of PG Studies in Sustavrata, JSSAMC Mysuru, present before you another feast of knowledge. CME on the occasion of World AIDS Day 2020 on the topic Global Solidarity Shared Responsibility by Dr. Prashant B, Assistant Professor, Department of Community Medicine, Mysuru Medical College and Research Institute, Mysuru. Now it's time to welcome the gathering. I wholeheartedly welcome our guest speaker, Dr. Prashant sir. Welcome, sir. It's my pleasure to welcome our HOD, Professor in HOD, Department of Sustavrata, Dr. P. Sudhakar Reddy sir, all UG and PG students to the CMI. Now, it's a privilege to have a glance at the achievements of Dr. Prashant sir. I call upon Dr. Rutsa Raj, final year PG scholar, to
Good morning, one and all. It's my pleasure to welcome Dr. Prashant B. Sir, Assistant Professor, Department of Community Medicine, Mysore Medical College and Research Institute, Mysore. Sir has done his UG from the Mysore Medical College and completed post-graduation in Community Medicine from KGMC, Lucknow. Sir has done advanced courses in diabetes and cardiovascular diseases and certified courses in management of thyroid disorders and fellowship in aesthetic medicine. He received golden medal from the Honorable President of India during his post-graduation. Sir is also an honorary member of International Epidemiological Association. Sir is a national trainer in biomedical based management and occupational health. Sir has written 2 international books published by Lombard Academic Publishing House, Germany. Sir has more than 25 publications in national and international index journals. Sir has presented research papers in various conferences, including International Conference at Kuala Lumpur, Malaysia. Sir has awarded Millennium Award by Karnataka Association of Community Health. Sir is currently the site principal investigator of research collaboration with Wellcome Trust, Department of Biotechnology, Indian Alliance Project, and a multi-centric COVID study conducted by Jayadeva, founded by US AIDS, and also for ICMR, BCG trial among elderly. I once again welcome you, sir, for the session. We are eagerly waiting you to hear from you, sir. Welcome, sir.
Thank you, one and all. Am I audible?
Yes, sir. It's loud and clear, sir.
Thank you, one and all. Good morning, one and all. I thank the JSS Ayurvedic College for giving me the opportunity. So you are sharing the slides. Hello. Hello. Hello.
I'll do it, sir. I'll do it, sir.
Oh. On this occasion of World AIDS Day, 1st December 2020, next slide, please. It's a global day of action on HIV and AIDS, a day to get the facts on HIV and AIDS. It's a day to show our support for people living with HIV and AIDS, and it's a day to get involved, all of us, in the prevention and control of HIV. The World AIDS Day was first observed in 1988, December 1st. Next slide, please. As we all know, what is the difference between HIV and AIDS? HIV is a human immunodeficiency virus. It is a retrovirus. It has two antigenic variants, HIV-1 and HIV-2. Because our target audience today is third year BAMS students, so I will focus more on the basics. Then in the last few slides, I will focus on the theme for this World AIDS Day. Human immunodeficiency virus is a retrovirus having two variants, HIV-1 and HIV-2. Next. It damages the immune system, and AIDS is the terminal stage of the HIV infection. HIV and AIDS are not synonymous to each other. So AIDS is acquired immunodeficiency syndrome. Next slide, please. So the difference between HIV and AIDS is HIV is an infection. AIDS is a terminal stage of the HIV infection. HIV and AIDS are not synonymous to each other. So HIV is otherwise known as a slim disease or a modern day pandemic. So I will start up the session with an interesting story on how the HIV was discovered. And to know, I don't want to bore you people with the facts and figures. So regarding the incidence prevalence, a single line that will emphasize the HIV as a global public health problem is every minute 5 people die from AIDS and 9 people are infected with HIV every minute in the world. This single sentence summarizes the importance of the HIV as a global public health problem. And it was the first national program which was started even when the first case of HIV was detected at Chennai in India in 1986. Immediately within 1 year of the first case of HIV, Government of India started a national AIDS control program and national AIDS control organization. It was the first national program which was the Government of India has taken so rapid steps, and it is one of the, apart from the World Health Day, the World AIDS Day is one national day which is observed globally throughout the world. Next slide, please. So I will start off with a story regarding HIV discovery. So 1978 and 79, 1980 and 81, there is a sudden rise in the sale of the pentamidine drug. So most of you are aware of the drug called pentamidine. It was a drug of choice for pneumocystis carinii pneumonia, which is now called as pneumocystis cerevisiae. There was a sudden increase in the sale of this drug in the 4 corporate hospitals of San Francisco and California region of the United States, where there is a more density of the population of the African Americans rather than the Native Americans. So, of course, the pharmaceutical companies were very happy that the sale of the pentamidine drug has increased by 10-fold, 20-fold. But very few intellectual people were interested to know why this is happening. So then they analyzed the data, whatever they obtained from, compare the data between 1978 and 79 and 1980 and 81. So they were clueless again. The commonest indication for prescribing pentamidine before 1978-79 is also pneumocystis carinii pneumonia, and 80-81 is also pneumocystis carinii pneumonia. And most of, whenever we are studying our subject, the Swasthata or community medicine, so you'll be having so many 2x2 tabulations. So just to emphasize, without the 2x2 table, we would not have discovered the HIV virus. I will tell you how. A simple tabulation made by the staff nurse during her leisure time by that particular data, comparing 1978 and 79 data and 80-81 data of the 4 corporate hospitals in San Francisco. She tabulated the data less than 15 to 64 and more than 64. Pneumocystis carinii pneumonia was a disease of the elderly and immunocompromised. And 1980 to 81, it was the age shift. That is more of a people that are affected by this pneumocystis carinii pneumonia is the 15 to 64 age group. That led to the conclusion that there is something that is happening that is causing the destruction of the immune system. That was the first breakthrough that led to the discovery of the HIV virus. Then they only interviewed people with age group of 15 to 64. They excluded the people who are in the extremes of age group. Then they collected all the possible history, including the past history, the family history of chronic diseases, the sexual and reproductive history, menstrual and obstetric history, everything. Then they found out that there is a cluster of commercial sex workers, homosexuals, where the African Americans are known for their violent sexual behavior. Then they found that they led to the conclusion that there is something that is transmitted through the sexual transmission that is affecting the immunological barrier of the human beings. Then they collected all the possible body secretions, the semen, vaginal secretions, sputum, blood. Then that led to the discovery of the HIV virus. This is a short story regarding how exactly the HIV virus was discovered. Without that simple tabulation, you would not have discovered the HIV virus. Then coming to the type of, then going to the HIV epidemiology, we need to understand some of the high risk groups. So HRG, these are all the common abbreviations we often use in the HIV epidemiology. The high risk groups, the HRG means high risk groups, that is MSMs, male having sex with males, female sex workers, and intravenous drug users. The bridge group is one of the special group in the HIV epidemiology. The bridge group is the one which connects which transmits the link. That is an important link in the chain of transmission of HIV infection from high risk groups to the general population, the clients of the commercial sex workers, the people who are having sexually transmitted infections as well as the reproductive tract infections like bacterial vaginosis, gonorrhea, syphilis, trichomonas vaginalis, and migrants and people who are living in the conflict areas and partners of the intravenous drug users. And generally, whenever we are doing a HIV prevalence surveys or sentinel surveillance, generally the antenatal mothers are taken as a proxy measure of general population. What do you mean by the word proxy? That means whenever you are assessing a prevalence surveys, 50% of the general population data is collected from the antenatal mothers. With the adult HIV prevalence of 0.27% in India, even though our access to antiretroviral therapy centers, there are so many ART centers, the access is increased, the testing has increased dramatically, still we have the infections is on the rise. That is, people living with HIV and AIDS are on the rise. That is, PLHA is on the rise. That's why the government of India started with the concept of getting to zero. There are 3 zeros in that. So even though the HIV infections is on the rise, so 0 new infections, we should at least reduce the new infections to 0. And we should reduce the HIV related mortality to 0 because of thanks to the antiretroviral therapy. And 0 discrimination. There is a lot of social stigma and discrimination attached to the HIV. So these are the 3 zeros you need to remember: 0 new infections, 0 HIV related mortality, and 0 discrimination. Getting to 0 is the current trend of HIV infection in India. Next slide, please. And as far as the HIV epidemiology is considered, we have the different types of HIV epidemics. Previous slide, go to the previous slide. Previous one. The next slide. So the HIV epidemics, they are actually divided into low-level epidemic, concentrated epidemic, and generalized epidemic. Whenever we have the high-risk group population having a prevalence of more than 5% and the general population having more than 1%, then it is called as a generalized epidemic. Where the concentrated epidemic means when it is a high-risk population having more than 5% prevalence and general population is having less than 1% prevalence. The low-level epidemic means less than 1% in the general population and less than 5% in the high-risk groups. This is the global classification of the HIV epidemic. Similarly, the states have been categorized in India as category A, B, C accordingly. The category A is more than 1% in the high-risk general population and more than 5% in the high risk groups. Most of the southern states, including Karnataka, comes in the group A. And similarly, the districts are also categorized into A, B, C, D according to the high prevalence to low prevalence. One of the most important, the misconceptions are we have so many myths regarding the modes of transmission. Still, we think that we know everything about the modes of transmission of HIV. So one of the more, all of you are very well aware that the most common mode of transmission of HIV infection is through the heterosexual route. That is accounting for 88.2% of the infection, and homosexual 1.5%, and parent-to-child transmission to 5%. Intravenous drug use is 1.7%, and blood is 1%. Some of the things I wanted to stress upon regarding the modes of transmission is whether the male to female carries a more risk or female to male carries a more risk. So HIV positive male have chance of transmitting the infection to its counterpart female rather than the female to male, because in the female, the vaginal surface area of the genitals is more, anal orifice and vaginal orifice are nearer to each other, and semen is a much richer source of HIV virus rather than the vaginal secretions. And similarly, the anal versus vaginal and homo versus hetero. So the anal orifice, because the chance of injuries are more, the homosexuality carries more risk and anal sex carries more risk when compared to the vaginal risk. And there is a lot of debate regarding the wet and dry kissing, how much the kissing can cause the HIV infection, or even the oral sex can cause the HIV infection. There are so many research articles that has proven beyond doubt that saliva carries almost a no risk. Saliva or the kissing doesn't transmit the HIV infection. It was the old concept that kissing or the saliva is almost non-infectious as far as the HIV is considered. And what if some of the, as a practitioner, I get phone calls like this, sir, I have a sexual intercourse with a HIV positive woman only once. So what is the risk? The highest risk of HIV transmission is through the blood. If 1 pint of blood is transfused from a HIV positive person by chance, the chances are almost 100%. It is more than 95%. It is almost 100% if 1 pint of blood is transfused. That means if you say by one single act, the highest risk is through the blood transfusion, even though the most common mode of transmission is heterosexual route. Sexual transmission, that is 0.3%. Only 0.3% by a single act of, and similarly, the women are at a higher risk because the reproductive woman cervix appears to be a very good barrier for preventing the HIV. The teenagers and postmenopausal, there is a cervical thinning because they are at a higher risk of contracting HIV infection. And what about the tattooing, ear piercing, and acupuncture? If they are not properly sterilized, they can have a chance of communication, the transmission of the HIV virus. Coming to the parent-to-child transmission, the 25% in the antenatal period, that chances are high when the mother is newly infected or mother has already advanced to the stage 4, that is HIV infection. Stage 4 is AIDS. And breastfeeding, the chance of 14%. There is once again, this is a debatable issue, especially in a country like India, where the HIV positive mother can breastfeed or not. That is based on the AFSAS criteria, that is called the affordability, the feasibility, the safety. So if the HIV positive woman doesn't breastfeed, what is the chance that the baby is going to die from the malnutrition in a country like India? If HIV positive woman on the regular antiretroviral therapy, the risk is very low. So then how much risk that is carried by the breastfeeding? And coming to the next slide, please. And these are all the things, the common misconception, especially among the general public, if not by the healthcare professionals. The regular contact by the healthcare professionals are sharing utensils or cloths, sharing hands, regular social contact. Only thing is sharing the razors, the shaving razors can cause the transmission of the HIV virus. And as already told you, urine, the feces, saliva, tears, and sweat almost carries a very less risk. Almost you can say there is a no risk of transmission of HIV through these body secretions. Next slide. Coming to the clinical course of HIV infection. So all of you might have aware that there is a 4 stages in the HIV infection. There is the initial asymptomatic infection. then there is a stage called PGL, then there is a ARC. Okay. So initial infection, that is asymptomatic for 5 years. So person is looking absolutely healthy, absolutely normal. He doesn't have any symptoms whatsoever. So he is asymptomatic for 5 years. Most of the HIV positive persons asymptomatic for 5 years, the initial infection, and 75% infected people will get AIDS. As I've already told you, it is the 4th stage. The terminal stage of HIV infection is called as AIDS, and 3 out of 4 people will develop AIDS by 10 years. And all of you are aware of the period called window period, which is a very important period in the epidemiology of the HIV infection. Window period is seronegative infectious phase. That means to say the patient will be having a undetectable antibodies, the ELISA will be negative, where he is infectious to the others. That period is called as a window period. Initially, there was once again a debate regarding the window period, how much it is. It is generally from 6 weeks to 3 months. So if a person is having a negative ELISA, and as a healthcare professional, you think that the person is having a high risk sexual behavior or the high risk behavior, then you need to retest the person after 3 months. That is the importance of the window period. And with a regular ELISA, which is not detectable antibodies, so window period, we have other diagnostic tests like P24 assay, antigen assay, which can diagnose HIV during the window period also. So that P24 assay is coming, which is commonly used in the Western countries. No, it is used commonly in India also in majority of the ART centers. Then one terminology you need to understand regarding the clinical course of HIV infection is PGL, that is persistent generalized lymphadenopathy. As the HIV comes under the umbrella of STI and RTA, that is sexually transmitted infections and reproductive tract infections, inguinal lymphadenopathy is not taken into consideration. It is very easy to remember the persistent generalized lymphadenopathy, which is one of the very important clinical link for the diagnosis of HIV. More than 1, 2, 3, that is more than 1 centimeter for at more than 2 extra inguinal sites, that is present for more than 3 months. That is 1, 2, 3, 1 centimeter, 2 extra inguinal sites, and present for 3 months. That is called as a persistent generalized lymphadenopathy, which is almost a specific feature of HIV infection, which doesn't occur in any other disease. The next stage is the ARC, that is AIDS-related complex, where the opportunistic infections and cancer will come into play, like Mycobacterium avium intracellular complex, the cancers like Kaposi sarcoma, hairy cell leukoplakia, the HIV virus, otherwise called as adult T-cell leukemia lymphoma, which will cause human T-cell leukemia lymphoma. And the opportunistic infections are very common is the oral candidiasis, the oral thrush, the toxoplasma, and the diarrhea, which is common in HIV, is Isospora belli. So these are all the opportunistic infections and cancers that commonly, even one of the most important is tuberculosis. That's why the TB HIV coordination has been catching up by the government of India. So because of the stigma and social discrimination associated with the HIV, the STA and RTA approach was used by the government of India. And whenever you have visited any PHC in India, there is a big board called Suraksha Clinic. That is, any patient, even whenever I get a phone calls from my patient, if they are having a general symptoms, they will ask, sir, sir. If they are having some of the STA and RTA symptoms, they will tell, sir, nan friend sir, yen maadbodu. So these are all the things you often experience as a physician. So the STA and RTA symptoms, any lady coming with a vaginal discharge, white discharge for vaginum, the inguinal bibo, or the male coming with the inguinal bibo or the urethral discharge. So there are a syndromic approach. There is 7 color-coded kits that comes under the umbrella of NACO, National AIDS Control Organization, under the National AIDS Control Program. All the PHCs in India. So that is one of the approach which has a more fruitful results in the HIV epidemiology. And one more thing from the clinical course, one thing I need to stress upon is only thing in the clinical point of view, you need to understand the CD4 count, whether the CD4 count 13, the WHO started the ART less than 500 CD4 count, we have to start ART, that is antiretroviral therapy. And then the India started the antiretroviral therapy by 2004. At that time, they started a 3x5 initiative by the government of India, along with a collaboration with the WHO. That is 3x5 initiative means government of India planned to give the ART, the antiretroviral therapy, to 3 million people by 2005 when it was started by 2004. At that time, when started, Zidovudin and nevirapine are the important drugs. No, they are outdated drugs. I will discuss about that ART therapy later. So this 3x5 initiative is an important initiative taken by the government of India regarding the initiation of the ART. The current trend, I will underline this statement, because irrespective of the CD4 count, irrespective of the WHO clinical staging, it doesn't matter. Once the HIV positive, he has to be on lifelong ART treatment, lifelong drugs. That is like any chronic disease like diabetes and hypertension nowadays. So he is on lifelong ART center, lifelong ART therapy. The life expectancy will be same as anybody else. There will be quality of life will be better. There is no worry at all with the lifelong ART therapy. So it doesn't depend upon the CD4 count nowadays, and it doesn't depend upon the WHO clinical staging. Only thing you need to know as a clinical physician regarding the clinical course of the HIV is when to suspect HIV. That's all. There is all those WHO definition of AIDS surveillance, the WHO clinical staging, only of theoretical importance, no, which can be asked as a short notes in your exam. That's all. So if there is a persistent diarrhea for more than 1 month, persistent fever for more than 1 month, if there is having a weight loss of more than significant weight loss, that is more than 10% in the last 3 months. So these are all the things. Are if he is having a oral thrush or candidiasis, so then you will suspect HIV. So as a clinicians, we need to understand only when to suspect HIV, because the clinical staging and CD4 count are not the criteria to initiate antiretroviral therapy in all over the world, not only in India. Next slide, please. And coming to the diagnosis, as I already told you, in the antigenic structure of the HIV virus, we have the GP, the glycoprotein 120 and 41, which are the important antigenic structure from which the HIV vaccine we can bank upon. The HIV vaccine research is going on since more than 20 years now. It was started in early 2000. Glycoprotein GP 120 and 41 and P24 assay. As I already told you, HIV1 and HIV2, there are two clinical varieties. There is the P24 assay is also being added. P24, the utility of P24 as a diagnostic test in the HIV is the diagnosis in the window period. And one more important advantage is if a baby is born to a HIV positive mother, the ELISA will be negative in the first 6 months of life. At that time, either you can go for P24 assay or HIV DNA PCR. So that is the utility of the P24 has a diagnostic utility in HIV epidemiology. Generally, what will you do at all the ICTC center, that is integrated counseling and testing centers, and PPTCT, that is PPTCT center, the prevention of parent to child transmission centers. So in all these, there is a screening test we do in series, that is ELISA followed by Western blot. We have a 4th generation ELISA followed by Western blot. ELISA is a screening test which is having a higher sensitivity, and Western blot, which is a specific test which is having a higher specificity. Only after the Western blot is positive, we will start the patients on antiretroviral therapy. And one more special test, it is a TRIDOT test. Generally, we use in the labor rooms and prior to any emergency, because we don't have time to go for ELISA and Western blot. It's just like a urine pregnancy test kit. It is a very easy kit that will give the result within 2 minutes. TRIDOT test is HIV1 and HIV2, which will be tested. That is 3 dots. So TRIDOT test is generally used in emergency settings, like in the labor ward when the lady has entered with already a rupture of membranes with the true labor pain. So I mean to say, I will say the CD4 count in the present scenario is more for a prognostic purpose. So you have started a ART, whether the CD4 count is increasing or it is being stable, whether that is for the prognostic point of view, because when you start a ART, the CD4 count has to rise. So it is more of a prognostic importance rather than the diagnosis or for the initiation of the ART. Next slide, please. Coming to the prevention part of it, as all of you are very much aware that there is no cure, there is no vaccine for this, but we have very well and very effective. Even the side effect profile of antiretroviral therapy is very less nowadays. We have the ART, you can say it is a game changer in the HIV. Hello, am I audible? Then ART is a game changer. ART is a game changer. So it is a triple drug therapy. It's a simple mnemonic I have made. It is a TEL, that is tenofovir, efavirenz, and lamivudine. This triple drug therapy has to be taken lifelong, just like any other chronic disease once the HIV infection is diagnosed. And one more scenario we often as healthcare professionals often encounter is the exposure or accidental needle prick injury to a HIV positive case. That is the post-exposure prophylaxis. The funda is very simple. You have to test within 72 hours, and you have to the same triple drug regimen, which is TEL, the tenofovir, efavirenz, and lamivudine has to be taken for 28 days. And because of the window period risk, you have to retest after 3 months. That is the thing. There is no need to panic. The post-exposure prophylaxis, we have a very effective drugs. Once again, the triple ART has to be taken for 28 days. One more in the therapeutic point of view of the HIV infection, we have CPT, the cotrimoxazole, which is rarely used by the physicians nowadays in the clinical practice. The drug only has re-emerged by itself. It is the cotrimoxazole preventive therapy, which can prevent so many opportunistic infections in the HIV, especially the pneumocystis cerevisiae pneumonia, as we have already discussed. So cotrimoxazole can prevent a lot of opportunistic infections as far as the HIV positive person is considered. Next slide, please. There are so many approaches for prevention. The government of India, 2002, the National Blood Policy and Blood Safety Program was started by the government of India as a part of National AIDS Control Program. After this program, only the HIV screening was made mandatory for all the surgeries, even elective and emergency surgeries, and for the blood transfusion. So it was a national blood policy which actually emphasizes the importance of the transmission of HIV through blood and its products. As I already discussed, the 2004 the ART was started in India with Jidovidine and nevirapine. Initially, Jidovidine was a drug which has having a lot of side effects, especially the severe intractable myopathy. And nevirapine is most often which was used with a single dose of 200 mg of nevirapine and 2 mg per kg for the neonate, which will reduce the risk of 50% from the parent to child transmission. You are using nevirapine. Jidovidine and nevirapine as a therapeutic drugs are outdated. They are nowhere used in India. So only the triple drug regimen, what I have told, that is used in India. There is an interesting story about the condom vending machine. All of you are very much aware that the unprotected sex has enhanced risk of HIV transmission and safe sex procedures. The condom can prevent the HIV infection. So when condom vending machine, I think most of you will not be aware of what is a condom vending machine, especially because of the stigma and discrimination associated with buying a condom at a medical shop. the government of India started condom vending machines at the public toilets and easily accessible places. A 5 rupee coin will be put in the, then condom will be distributed. That is, condom vending machines were installed at the easily accessible places. And what happened is, one of the flavored condoms and all those varieties of dotted condoms are not there for the HIV prevention or neither for increasing the sexual pleasure. They are actually to avoid the misuse of the condoms. When this was started, the latex rubber factories, you see the mentality. All the latex rubber factories, all the distribution from the National AIDS Program used to go to the rubber factory and they used to melt it and they used to use it for rubber factory. So that was a scenario in a country like India. Then we have FHAC, that is Family Health Awareness Campaigns, as a part of health education and increasing the awareness, especially among the schools and colleges. So organizing debates, organizing quiz, and this kind of family health awareness campaigns was a part of a IEC activities, the behavioral change communication, information education, the IEC activities and behavioral change communication activities under National AIDS Control Program, FHAC, was started. Then the red ribbon, everybody well aware that red ribbon is a symbol of HIV infection. When Lalu Prasad Yadav was started a Red Ribbon Express. So Red Ribbon, effective IEC campaign for the prevention of HIV, so that we put our hands together for the prevention of HIV. Once again, the link worker scheme is a game changer in the HIV prevention and control in India, especially where the hard to reach areas, the link worker has been made as a link between the HIV infected persons and the healthcare system of this country. The link worker is specifically designed for STI and RTI, including HIV. And HIV Sentinel surveillance, that is, Sentinel means the portal of entry. Under this program, there is UAT, that means unlinked anonymous testing. There is no need to link the data, there is no need to reveal your identity, just get tested to enhance the testing. So even the STI and RTI clinics, the STD clinics, were built nearer to the high risk groups. For example, near the red light area, near the intravenous drug users areas. Then unlinked anonymous testing means there is no linking of the data. For example, you cannot trace that this belongs to the Mysore district or this belongs to the Dharwad district. So ultimately, the data will be added to the national data. That is, unlinked anonymous testing is Sentinel surveillance, as a part of Sentinel surveillance. Then, as a part of a pediatric HIV initiative, they started the ART regimens for the pediatric age group. HIV TB coordination, because it takes a lot of challenges and difficulties in TB diagnosis and TB treatment in antitubercular therapy, as well as the HIV initiation of the antiretroviral therapy. HIV TB coordination and tuberculosis is one of the most common opportunistic infections in HIV. HIV TB coordination has been taken as a special entity under the National AIDS Control Program, because it poses a lot of challenges in diagnosis as well as the changing of the treatment regimens. And the ART centers, the link ART center, you should be aware of this link ART center and what is ART plus center. The antiretroviral because there are so many, a person who is from HD Kotte because it is lifelong. Center means only the drug distribution centers. You can know Western that only as they act as a drug, as the drug compliance are called as a link ERT centers. You can call them working as a drug distribution center. The ERT plus centers are where the first line drugs like TEL, the tenofovir, efavirenz, and lamivudine are failing. You have to go for second line drugs. That means ERT plus centers. And centers of excellence where all the diagnostic facilities and all the first line, second line drugs and reserve drugs are there, and there is a counseling. So I am happy to tell that our ART center at KR Hospital is one of the centers of excellence for the HIV prevention. And in any HIV, the testing, you need to understand there is a pre-test counseling and post-test counseling. So before the test, you need to assess the high-risk behavior of the person. In the post-test, depending upon the test, positive or negative, even if the test is negative, if you think he is a high risk, you need to counsel them for reducing the risk behavior and advise him to retest after 3 months. If the result is positive, tell him that it is not the end of his life. The quality of life will be same and life expectancy will be same on lifelong ART, and motivate him to take a compliant with the ART regimen. So the integrated counseling and testing centers are actually fixed facility and mobile ICTs. The comes also and fixed facility ICTs. Like any other person, screening every pregnant woman at the subcenter, the prevention of parent-to-child transmission level, and the same triple drug regimen, the lifelong ART has to be started for all the pregnant women, irrespective of the CD4 count and WHO clinical staging. So I repeat it, once the HIV infected, the lifelong ART has to be taken, irrespective of the symptoms, irrespective of the clinical staging, irrespective of the CD4 count. And there is one more entity called early infant diagnosis, EID, using HIV DNA PCR at 6 weeks, and antiretroviral prophylaxis has to be given for infants till 6 months of age. And majority of when I am interacting with the ART center, the patients, they will ask, sir, I am a HIV positive patient, so can I have a child? So these are all the common questions. So yes, if you are unmarried, if you are not exposed to the, if you are unmarried, you are HIV positive. If you started once you are on a complaint to the lifelong ART, so you can have a child. The HIV load, the antibodies are even undetectable after certain years of ART. So you can still have a baby. Next slide, please. Next slide. Next slide. So Red Ribbon Clubs has been set up by the Government of India for adolescents, just to discuss what are all the physiological changes during menstruation and what is the, because the teenagers have a lot of doubts regarding HIV or sexually transmitted infection or regarding the safe sex procedures. So there the Red Ribbon Clubs have been set up, and there is every Thursday 3 to 5 at all the PSCs in India. We have the Sneha clinic being run as adolescent counseling centers, especially for the adolescents. There is a Sneha clinic has been built under the umbrella of National AIDS Control Program. Next slide, please. Coming to the current year theme, it is ending HIV or AIDS pandemic. It is a resilience and impact. The global solidarity and shared responsibility. Now we are in the era of international travel. So I have already told you the HIV or AIDS, World AIDS Day is one of the only the health related day which is observed globally. The global solidarity is needed. The resilience, what you mean by the word resilience is, next slide please. Next slide. AIDS 2020 calls action for resilience, because there is a lot of global changing health needs of the people. We are facing the era of uncertainties. The health needs and demands are changing. Even the people are going just for international travel, just for the sake of travel. And that resilience should be there for the HIV, especially we have to reduce the HIV related social stigma. Basically, every person has a human right to live with dignity. That is where the resilience is needed for us to insist on the fundamental human right for people living with HIV and AIDS, living with dignity, good health over a lifetime, and bounce back from all the diversities and help each other. They will have a, just like a Down syndrome clubs, we have Alzheimer's clubs, we have HIV clubs also. They can help each other, they can discuss each other, they can have their own clubs. And resilience is needed where there is a fragmentation of the response. Even there is a disparity among the experts. So there is every country, every state is facing the challenges. The priorities may be different, but our global common aim is to reduce the HIV infections and HIV related mortality and let HIV infected people will live as a normal people. That is, avoid fragmentation, remain united and inclusive to meet our common challenges. Resilience is needed to lead advocacy and program implementation. So we as I've already told you, it is getting to zero new infections, zero HIV related mortality, and zero discrimination. Until that, we have to increase the access to the ART centers. We have to increase the social support what they need. Next slide. And we need to have the resilience to advance science. As we have told you, the glycoprotein 120 and 41 324 assay, we have a lot of improved treatment regimens, because I already told you Judovidin and Nevirapine are outdated drugs. Now we have the improved drugs. The newer drugs are coming for the treatment of HIV. We are changing the ART regimens day by day. We have the generic options for the ART drugs also. We have the new preventive tools, and the research for HIV vaccine, the effective vaccine, is going on since more than 20 years. So the science has to be advanced for all these and identify the additional strategies for the behavioral change. Ultimately, what we aim at is accessible cure for HIV. As we know, there is no cure, but we are aiming for a cure. With so many ART drugs coming up, we can have an affordable and accessible cure for HIV. And we have to be resilient to fight against the laws that codify the stigma, the discrimination associated with it, the criminalization that restrict the gender equality. You might have seen in so many ads, like when a female goes to a medical shop to buy a condom. So that kind of ads you might have seen. That is the gender equality. There are so many laws that has to be passed regarding the discrimination associated with the HIV and the sexual behavior, and access to human right based responses. We have to be resilient to join with the advocates and scientists. It is not the reduction in the HIV is not only the responsibility of the healthcare professionals. We also have to be join with advocates, scientists to find the common causes. There is a social causes, the social pathology. We often say social causes, the common causes. Then only we advance into a universal healthcare worldwide. And we have to be resilient to address the demands of the long-term resources needed to achieve the global HIV targets and the national and international budgets. So next slide, please. So I will have few of my patient stories. So one person came with the history of tuberculosis. Still, what I mean to tell is some of the clinical experience I wanted to share you. One person came to my clinic with symptoms suggestive of the persistent oral thrush since 3 months. There is significant weight loss, and there are even he is having a Mycobacterium tuberculosis also. With the stigma and discrimination associated with it, he opted to die rather than to go for HIV testing. Even today also that is happening. And one more person, on the contrary, one person, he accepted that the HIV testing, then he immediately started the ART. Then that is his statement. He is telling that I am glad I accepted to do HIV testing. That actually changed my life. He is now very healthy physically, mentally. No, he is taking ART drugs. He is fine. Next slide, please. Next. That is getting tested is being a game changer. That is a patient experience. One more patient actually told she was a teenager. she was having a adolescent high risk sexual behavior. She actually came for me with asking for medical termination of pregnancy drugs, MTP drugs. Then I get tested for HIV. She told that initially my boyfriend didn't accept it. Okay. Later, when she was HIV positive, she started ART. No, she is almost having undetectable antibodies. So I told her, I counseled her that she can go for marriage and she can still have a baby. So she can still have a healthy relationships. Next slide, please. Next slide, please. So one lady in the middle age, she is having a teenage daughter. She actually told her daughter recently that I am HIV positive. Her daughter, a teenage daughter, is looking at her mother like a criminal and she is expecting her to die. That means to say the criminality part of it is one part. The second part is she thinks that as a teenage daughter that HIV is a terminal illness. She is going to die any day. Okay. That is not the case. So these are all the things, some of the stories I wanted to tell. Next slide, please. Next slide. Next slide. Next. And still we have the issues with the stigma and discrimination and confidentiality issues with HIV. And one teenager is telling the life living with HIV after becoming HIV positive is very difficult, sir. He was sharing that because he is a teenager, he is discovering what exactly the life is, the discovery that society will not accept because of the virus. The young person, he experienced the confidentiality is still an issue with HIV. Next slide. I will end my session by the famous statement by Nelson Mandela. The history will surely judge us harshly if we do not respond with all the energy and resources that we can bring to bear in the fight against AIDS. Ask yourself what you can do as a global citizen in the fight against HIV and AIDS. We must never forget our own responsibilities. It is a global solidarity and it's a shared responsibility. Everybody, every individual have responsibility to fight against HIV to reduce it as a public health problem. I once again thank you, JSS Ayurvedic College, for giving me the opportunity, especially the Dr. Sudhakar Reddy, Professor and HOD of Swastharatta. Thank you, one and all.
Thank you, sir.
Thank you, Prashant sir. It was indeed an informative session. Thank you so much for enlightening all of us with your knowledge. Now it's time for the prize announcement. As we all know, we have conducted from the Department of PG Studies in Sustavita, we have conducted an essay writing competition on the occasion of World AIDS Day, and it's time for the prize announcement. So I call upon P. Sudhakar Reddy sir, Professor and HOD, Department of Sustavita, to announce the prizes.
Good morning to all. Today's guest speaker, Dr. Prashant, his scholars, and their colleagues. On the occasion of World AIDS Day, we have conducted a writing competition on the topic Global Solidarity Sharing Responsibility for UG, PG internees of JSSAMC, JMC, Government Naturopathy Yoga College, JSS College of Nursing, JSS College of Physiotherapy, and we are happy to say that we have received within short period 18 essays to us. After scrutiny, we have chosen 4 prizes. And first of all, I would like to say thanks to all college principals, JSSAMC, GMC, GNYC, JSS College of Naturopathy, and JSS College of Physiotherapy for their cooperation and the encouragement of their students to participate in the essay writing competition. And among the 18, the first prize was won by Dr. Shivani Prasad, BNY's second year, Government Naturopathy and Yoga Medical College, Mysore. Congratulations, Shivani Prasad. And second prize goes to Hitesh Prasad, year, Government Ayurvedic Medical College, Mysore. Congratulations once again to Dr. Hitesh Prasad. Again, second prize shared by Sanjana N, BMS second year, Government Ayurvedic Medical College, Mysore. Congratulations, Sanjana. Third prize goes to Tessa Matthew AP, BSc Nursing second year, JSS College of Nursing. Congratulations once again to Tessa Matthew. And fourth prize, consolation prize won by Dr. Harshita BY, fourth BMS JSSAMC Mysuru. Congratulations, Harshita BY. Once again, congratulations to all the participants. Once again, all the principals for their encouragement and their cooperation. Thank you very much.
Once again, congrats to all participants and prize winners. Now, I would like to request Dr. Shashibindu sir, NSS officer, JSSAMC Mysuru, the vote of thanks.
Pranams to His Holiness. It's my proud privilege to propose vote of thanks for this event of International AIDS Day organized by the PG Department of Sastavita in association with NSS unit of JSSAMC Mysore. So we have started with last week essay competition for the students of Mysore, and we have got very good response from different colleges within a short duration. And today we have organized CME on the theme Global Solidarity Shared Responsibility, a much needed topic to discuss for the purpose to create awareness towards AIDS. It's my great privilege to thank today's guest speaker, Dr. Prashant B, Assistant Professor, Department of Community Medicine, Mysuru Medical College and Research Institution. Sir, within a short notice, sir has responded and delivered an informative lecture. So thank you, sir. I would like to extend my thanks to our ever supportive and enthusiastic beloved principals, Dr. Sarvesh Karsar sir, for giving opportunity to organize this event. I would like to thank our Dean, Dr. Rajesh Utpudi sir, for his continuous support. I would like to thank the organizing secretary and HOD PG Department of Swastavrita, Dr. Sudhakar Reddy sir, for arranging this event, and all the staff members and PGs of department and MS joining hands for the smooth conduction of this event and making this event a grand success. I would like to thank students who have participated in essay competitions and principals of that college for joining hands for this event and making this event successful. And special thanks to Dr. Madhusudan sir for the technical support. And last not but the least, I would like to thank all the teaching faculty, PGs, UGs, non-teaching staff who were directly and indirectly involved in this event and making this event a grand success. So thank you one and all.